Welcome. My name is Jennifer Roeder. I'm a communications consultant for APFED, and I'll be moderating today's webinar. Today, we'll learn about navigating treatment choice in EoE from Dr. David Leiman. Dr. Leiman is a gastroenterologist at Duke University Medical Center, where he is a member of the Duke Clinical Research Institute. He is an active clinical and health services research focusing on care delivery. He currently runs several EoE clinical trials at Duke. Welcome, Dr. Leiman.
Thank you so much, Jennifer, for that really nice introduction. And thank you so much for the opportunity to present today. I'll go ahead and get started and share. Well, thanks again for the invitation to APFED, and really looking forward to this conversation. As Jennifer said, my name is David Leiman. I'm one of the gastroenterologists at Duke University, and I am the director of the esophageal program there. And in that role, I've had the opportunity to run several clinical studies related to EoE, and really some of the great news about that is that there are a lot of options now that we didn't have even just a few years ago. And we've got a peek over the horizon, which shows that there are probably even more options coming down the pike. Of course, what that means with more options is that there are more sort of opportunities for thinking through those, and we are at risk for the so-called tyranny of choice. And that means that there will be increasing complexity in how we think through the specific options and what's really best for each individual. So I'd like to spend some time over the next hour talking with you all about that. And without further ado, we'll go ahead and begin our discussion on navigating treatment choice in eosinophilic esophagitis. These are my disclosures. And I thought it would be helpful to ground us all with a discussion of a patient story. So this is a 29-year-old woman who presented to the emergency room with sudden onset mid-chest pain in the middle of a meal. She's had some swallowing trouble for several years and usually forces things up when they get stuck. But this particular episode has lasted several hours, which has prompted presentation to the emergency room. She says that she was diagnosed with asthma as a child but grew out of it, and also has seasonal allergies, which are much worse since moving to North Carolina. She has no prior surgery, but is recovering from a stress fracture in her leg, which she says is attributed to running multiple marathons throughout the year. Her only medication right now is a prenatal vitamin. She and her husband are trying to conceive, and her family history is notable for a sister with celiac disease and says that I grew up in a gluten-free house. She did have an upper endoscopy performed, and a food bolus was removed. There was some inflammation that was noted in the esophagus, and there was narrowing there as well. Biopsies were taken, and these samples of tissue confirmed eosinophils, which suggested a diagnosis of eosinophilic esophagitis, or EoE. So what might we choose for treatment? And I'd like us to think about this in a couple of different ways. One as the patient, one as the parent or the caregiver, or even as the provider or part of the other healthcare team. And how would we navigate thinking through that? So we have a number of different options we might choose from, and also a number of trade-offs for us to consider when making that decision. Is it a high-dose proton pump inhibitor, or PPI, also called an acid blocker? Is it perhaps twice a day PPI's higher dose? Maybe a swallowed topical steroid, biologic therapy, structured elimination diet, or perhaps we plan to dilate and then observe course after that dilation of the esophageal stricture or narrowing. And what about the trade-offs to consider? There's this other history of allergies. There's a question about bone health with the stress fracture, considerations around pregnancy, also an experience with diet-based treatment, and also knowing that there is the stricture or scar tissue that could and perhaps should be dilated. And so thinking through all of those questions is really the crux of our conversation today. I'd like us to keep those in mind as we move forward. The goals of this presentation then are really to review important updates in EoE, also to highlight some impactful and recent data around the evolving field of treatment options, which we've alluded to, and then discuss shared decision-making in the context of EoE care. To ground us in all of that, it would be helpful to talk a little bit about some background in EoE. This is going to be familiar to many, if not most of you, but EoE is a chronic allergen immune-mediated inflammatory condition that affects the esophagus. We can see in this cartoon that the number of eosinophils in the esophagus should be 0. And if there's more than that, then something is amiss and needs to be investigated. But there are a number of reasons why that might be. And so that's part of the job of the healthcare team, is to investigate, is this in fact eosinophilic esophagitis, EoE, or is there something else going on, or perhaps more than one thing going on? This is in contrast to the normal number of eosinophils, which might be different throughout the GI tract. And we will come back to that in just a minute. But importantly, this is more than just the number of eosinophils that are present, but this is really a clinical pathologic disorder. And by that, what I mean is there needs to be some symptoms that accompany this, not just an abnormality that's noted on a biopsy. These symptoms of dysfunction typically include things like swallowing, pain, difficulty moving things down, a sensation of moving slowly through the chest. Those biopsies, as I mentioned, do need to have an eosinophil predominant inflammation, and that this may occur in an overlapping scenario, or perhaps it's isolated just to the esophagus. And as we've mentioned already, alternative reasons have been excluded. And the reason this is important amongst many others is that EoE is increasingly common. The number of people who are being diagnosed with EoE is rising, as we can see in this diagram here. That's been fairly consistent over time and has been consistent in a number of different locations. But EoE is not a condition that people die from. In fact, there's good evidence that there is no increased risk of cancer related to this. People are not dying from EoE. In fact, they're living longer with EoE. And for that reason, the prevalence is increasing as well, which again mirrors that trend we saw before in the second graph here. And because people are living longer with EoE, and because it sometimes takes a long time to make that diagnosis, we can evaluate how things change over time. This is a graph that shows there are a number of different ways that this may present for what we call phenotypes. So as people live longer and before they receive treatment for EoE, the chances of having a normal esophagus go down, whereas the chances of having inflammation on esophagus biopsies goes up, and then ultimately can lead to scarring, or what's called fibro or fibrostenotic conditions, which we can see again in the graph. The likelihood of that increases as people live with EoE longer. And then importantly, when EoE is untreated, seen in a different way, the chances of needing a dilation for a stricture also goes up. We can see that shown a different way. This graph, this is a cartoon showing that, again, evolution over time from normal to inflammation to a mixture of inflammation and scar or fibrosis, eventually leading to fibrosis or fibrostenosis. And it's that period of time or evolution that may also be in part for the reason why symptoms can change or evolve over time as well. As we can see on the right, that whereas this may be something that's diagnosed at any age, the symptoms with which people present may change. And part of that may be due to the sophistication or ability of some people to describe those, especially as young kids, the symptoms that they're feeling, but also because of the evolution of the condition itself. So early on, presenting potentially with feeding problems, feeding intolerance, vomiting, abdominal pain, and then as more scar tissue forms, leading to more dysphagia or difficulty with swallowing. Again, that sensation of food moving slowly through the chest, and then again, eventually may present with food impaction, as we saw in that discussion with the patient early on. What this looks like endoscopically is shown here. We can see some very typical features as shown in the cartoon on the left. We can see that endoscopically on the right. I mentioned that EoE sits within a larger context, and within that eosinophilic gastrointestinal diseases category, EoE is situated here, and that's really going to be the focus of our discussion. But I do want to keep in mind that EoE may exist and overlap with other conditions as well. This slide is really not meant to be intimidating, and I don't want to get into the weeds of this entire pathway, but what I do want to highlight with this cartoon here is a number of different things. Firstly, that EoE is triggered by several prototypical things. primarily foods that we eat, highlighting several of the important ones over here on the left, including milk or dairy, meat, and eggs, but also other things in the environment, including aeroallergens, stuff that is much harder for us to control. And that can trigger this inflammation or this cascade, which again is shown in this diagram. And we won't be going through each of these individually, but what I want to highlight is that there's been an incredible increase in our understanding of the pathway, which has also presented a number of opportunities for treatment. And we will be going through those as we move forward. So I'll pause there as we sort of consider some of that background. I wanted to highlight this image, which actually is an AI-generated image of eosinophilic esophagitis, which is not anatomically correct, but at least it gets to that point of there's some inflammation in the esophagus and there's some narrowing as well. So certainly some room for increased understanding for all of us, but including AI as well. And I'd like to highlight how some of that understanding has again evolved. So we'll move into some of the discussion around treatment options. Many people who are initially diagnosed with EoE or even who have symptoms that may suggest EoE are given a prescription for a PPI or a proton pump inhibitor. And just several years ago, this was used as a therapeutic trial. This was something that was used to exclude the overlap or potentially the coexistence of gastroesophageal reflux disease or GERD. And so patients were given a prescription and then reassessed. But it was clear that many people who were ultimately diagnosed with EoE also responded to acid blockers. And that was the so-called PPI responsive esophageal eosinophilia or PPI-RE. But it was clear that it was very difficult to distinguish those people based on the way things looked endoscopically, as you can see in these pictures, A, B, D, and E. And then on biopsies, C and F, it would be impossible to distinguish on this basis alone which one of these people was diagnosed with EoE and which one of them just responded to PPI but wasn't classified as EoE. And the symptoms were similar. And so ultimately, this led to an update in the consensus or agreed consensus recommendations, which was to remove this idea of PPIs as a therapeutic trial to exclude some alternative source, but rather as a treatment in and of itself. And that's really simplified and shown here in this diagram. What I want to emphasize is that now we think of PPIs as one of our many modes of treatment for EoE. The question being posed is, should proton pump inhibitors be used in patients with EoE or esophageal eosinophilia? And a systematic review of a number of trials, almost 24 observational studies, showed that there was a 41% response rate in adults. A more recent study looking at real-world data, so in other words, extrapolating from the experiences of patients in a European database that had over 10% of patients were pediatric patients, found that again, efficacy was pretty similar, close to 50%, with a symptomatic improvement in over 70%. It did seem as if PPIs were better earlier on during that inflammatory phase, but that it was also helpful in remission. And I want to highlight one other very recent study, which seems to suggest that it's not just being on these medications, but being on higher doses of these medications that really does seem important to achieving that remission. But there are, of course, other options as well. Importantly, we have swallowed or sometimes called topical corticosteroids. The typical options in the past have been either a budesonide slurry or a fluticasone spray. These are options that were appropriated for other indications, usually asthma. The budesonide slurry was something that many people had to either mix themselves at home, something viscous, for example, artificial sweeteners or honey, that sort of thing, or have to go to a compounding pharmacy to get made, and then would take this at home versus a fluticasone spray, again, used for asthma, but used incorrectly for asthma when it was being used for EoE, specifically spraying it into the mouth and then swallowing it rather than breathing it in. The efficacy for these is about 60%, and fluticasone is not superior to budesonide. In other words, both of these are reasonable options. And in fact, they do reduce the likelihood of food impactions and dilations. And importantly, when these medications are stopped, the chances of remission, or in this case, needing a dilation or having recurrence goes up, which we can see again here on the right, which is to say that likely discontinuing medication would be associated with a recurrence. And for that reason, maintenance or continued use is definitely recommended. I want to take this opportunity to share some other exciting news, which is really one of the main points of this discussion, which is that there are more options now than even just a few months ago. So for those of you who are going to be watching this in the future, this is to time date this. This is about 6 months after the approval of budesonide oral suspension. We have some data here which looks very similar in terms of efficacy to what I just showed you. The other swallowed topical steroids, and budesonide oral suspension, or as the brand name is called, EoE, was FDA approved in 2024 for patients over the age of 11. It was approved for 12 weeks and at a dose of 2 milligrams by mouth twice a day. This comes with several potential advantages, including that it comes in a premixed formulation, similar to a ketchup packet where instead of having to mix all of this or go elsewhere, it comes premixed, and that packet can be opened and then swallowed directly. There are, of course, some other questions that naturally follow from this approval, which is, well, what happens after 12 weeks? What if my dose isn't 2 milligrams twice a day, which is higher than many people use right now? And these are some open questions and areas that we certainly need to continue to explore, but I think again brings to mind the complexity of thinking through those treatment choices. So if we summarize that treatment approach as of just a couple of years ago, we can see that in this graph, where when other reasons for inflammation are excluded on the right, we focus on the diagnosis of EoE, or eosinophilic esophagitis, and we have on one side medical therapy, which might include PPIs, or those proton pump inhibitors, or those swallowed topical steroids. But we also might think about dietary therapy, and we will come back to that in just a moment. And then if there's no response with one versus the other, we might switch between the two. Perhaps a dilation is needed if there's scar tissue or that fibrostenosis, and then maintenance therapy would be recommended going forward. But fortunately, we now have even more options. Many of you may be familiar with dupilumab, or as it's known by its brand name, APFED. This was approved a couple of years ago at this point, and it was on the basis of these data, which is to say there was a significant improvement on histology or biopsies, and there was a significant improvement in symptoms as well. And whereas in other allergic conditions, this is used every other week, for EoE, this was approved once a week, primarily on the basis of this, which we can see on the bottom right, which is that in people who used the dupilumab every week, there was a significant improvement in their symptoms. And for that reason, it was FDA approved, and subsequently for ages over 1 at 300 milligrams weekly. I will say, as a caveat, I'm an adult gastroenterologist, and I appreciate that the dosing may be different in pediatric realm, but that at least for adults, this is once a week. There is no loading dose needed, and they provide some additional opportunities, particularly if there may be experience issues. For example, people who have unpredictable schedules or things like this, that taking a medication once a week may be able to provide a significant number of advantages around adherence, even above and beyond some of the other efficacy. And when we think about the efficacy, not just in the clinical trials, but again, in some real world evidence, we see that the efficacy for dupilumab is probably around 70 to 80%, although that data continues to be accumulated. So when we integrate all of that and consider where this new medication fits into that treatment paradigm or algorithm, we see that there are a lot of different options, as outlined in this graphic here. When somebody is newly diagnosed, one could consider dupilumab up front, and there may be some reasons to sway us to make that decision or not. Perhaps there are some other atopic or allergic conditions that this medication would work for. So to simplify the regimen, it's one medicine versus multiple. Perhaps if there's more advanced disease, to come back to that idea of scar tissue or fibrostenosis, that perhaps the other medications may not be quite as effective as dupilumab. Or perhaps if people have already tried some of those other medications and they're not responding, this perhaps may be the next level of treatment. And when we think about those treatment endpoints or how do we measure success, there's a couple of different ways that I think we should highlight. Clinically, we like to integrate a number of different aspects. Firstly, the histology, we've mentioned this a few times. What that's referring to is the biopsy. So when you take samples of tissue, how many eosinophils as a rough measure are we seeing in terms of managing success? And that has a really good correlation with the endoscopic findings, some of which we've already seen and is measured by something called ERES, looking at some of those both inflammatory and then fibrostenotic or scar tissue related findings. And then, of course, importantly, how are patients feeling? What is the improvement or lack thereof as it relates to swallowing dysfunction, dysphagia, discomfort with eating, or again, that sensation of delayed passage of food? And we try to integrate all of these together, and I think that's nicely highlighted on this diagram here on the right when we're thinking about a complete response. So we want to integrate, again, lots of different endpoints, thinking about the symptoms. Are those improving? What does it look like endoscopically, and what does it look like histologically? And hopefully we get that bullseye there in the middle with this complete response. But we appreciate that there are instances in which people may have a response in one domain, but not in another. And we need to begin to think about that. One of the reasons may be because there is still some continued angst, stress, or anxiety around eating, even if some of the inflammation is healed, or perhaps there's now some residual scar tissue that needs to be dilated in order, again, to help with some of those symptoms. And it's important to highlight how some of those behaviors may manifest. And these are really important questions, not just for us as clinicians to be thinking about, but for patients and caregivers to be thinking about, considering, and watching out for as well, these so-called impact behaviors. And we'll go through these. Is somebody imbibing, drinking a lot of fluids with meals, taking sips perhaps with every bite to help with moving things down? Somebody modifying their foods, avoiding certain foods because they're worried about that getting stuck, taking a very long time to finish a meal, perhaps finishing later or last consistently, avoiding, again, hard textures. Things that often come up include stringy meats, dry foods like rice or bread. And it's important to point out that although these may be the sources of symptoms, they are not necessarily the triggers in trying to tease those two things apart as well. People chewing excessively, again, this typically can lead to longer times finishing a meal or turning away when taking medications. And I'd like to pause at this time and share some reality TV, which may be something others have seen. And so bear with me as we cue this up.
Talking about when we were talking about the food thing and you said you had an esophagus problem.
Yeah, I have a narrowing in my esophagus. I don't take any medicine for that.
After hearing about Sutton's small esophagus,
You're gonna tell everybody I don't eat,
But you don't.
and you know that I have an esophagus. You know that I do.
I know you told me that.
does she have like an esophageal sphincter issue or something? Or like,
I'm not a doctor.
does it hurt? Anything, but like narrow esophagus, that's a symptom of something. That's not a medical diagnosis. If you have like a stricture in your esophagus, all you do is chew your food more. If you
At this point, I'll come back to slide presentation. As we think about what we just heard, and this is, of course, reality TV, but what the suggestion here is that modifying foods or modifying behavior may be sufficient. And I hope that comes in conflict with what we just discussed, which is that those might actually be signs that there's something else going on that needs to be addressed. And whereas avoiding certain foods because it triggers symptoms is a sign that something should be managed, diet actually, as we've already discussed, is an important pillar in the management of EoE. But this is a systematic approach to managing diet, not a haphazard approach to avoiding certain foods. What I really like about this diagram is that it highlights that there is some incremental benefit in restricting systematically foods from the diet, or the so-called elimination diet. On the bottom, we see a 2-food elimination has a success of about 40% or so when eliminating dairy and wheat in this study, and it's nice to be able to see how that tracks pretty similarly for both adult and pediatric patients. As we remove more foods from the diet, in this case, soy and eggs, again, incremental benefit, and then the prototypical 6-food elimination diet, where nuts, tree nuts, fish, and shellfish are removed, we get, again, further incremental benefit. That was a study from several years ago, and this is a systematic review, or what we call a grouping of a number of different studies. And we could see that the overall success rate is fairly similar. With just a 1-food elimination diet, though, we see success around 50%. But then some diminishing returns as we remove more and more foods. The 4-food elimination diet or the 6-food elimination diet, again, having diminishing returns. And so the emphasis now being a little bit more on not a targeted elimination diet, as the last line would suggest based on allergy testing, but more of an empiric elimination diet, focusing, as you can see on the right, at things like dairy and wheat in particular, given that those are very common triggers. When we think about efficacy, again, that being similar to what we would see with some of our other medications, it doesn't suggest that it's definitely one versus the other that we should be choosing, but that rather there's now some choice around this. One of the trade-offs to consider when thinking about an elimination diet, in addition to how successful it may be and whether it could be implemented and adhered to, is what that process of figuring out specific triggers looks like. We can see that can be approached in a couple of different ways. On the left, we see the step up, and then on the right, we see the step down. So either eliminating a couple of foods or one, and then maybe a second up front, and then serially restricting, or taking a lot of foods away all at once, and then serially reintroducing them. One of the issues that comes up with this is that it requires potentially a number of endoscopic evaluations, because unfortunately, as of right now, that still remains the primary way that we can monitor for success. This can be a little bit of a diagnostic conundrum for folks because it does take a while, and that's something certainly to consider when thinking about the approach. All of this, of course, is in service of reducing that inflammation, which again, AI generated a diagram of what that might look like. And so we'll use that as a moment to pause to think back about some of the current treatment options. I will spot you that dupilumab is not part of that, and that's because this survey study was published before dupilumab was approved. But what I want to highlight is that when clinicians are thinking about and reporting what they're recommending as first-line treatments can vary. You can see that diet is relatively infrequently recommended upfront in adults, that some doses of PPI are frequently recommended, but swallowed steroids are recommended almost a third of the time. So quite a number of, quite an amount of variation. And one of the reasons for that may be because there's a couple of different frameworks or sort of conceptual models to think of when we consider these different treatment approaches. One of them is shown here, which suggests that perhaps treatment is like a menu, that if one, you could choose one or another, or perhaps some other option, and that all of these are equally acceptable. And in many ways, that's true. We've talked a little bit about some varying efficacy between these different treatments, but we also appreciate that these vary in terms of the type of administration, the frequency of administration, efficacy, whether or not these have been approved specifically for EoE, and that some of those may matter when people are making the decision about their treatment choice. Another way of thinking about this treatment is perhaps like this, as illustrated in this pyramid, where there may be a decision to start with one treatment and either switch between one or the other, whether it's medications or diet. And if one is having an incomplete response, think about combination therapy, and then eventually perhaps work their way up to biologic treatment. Of course, there are opportunities to skip between one versus another rung here, or perhaps use dilation as a way to manage symptoms. But this pyramid may also, in theory, be inverted, where perhaps biologic medication is recommended up front, success rate may be higher, and then slowly wean down the treatment. And I think what this highlights is, again, that there's a couple of different ways to think through this, which is a challenge both on the provider side as well as on the patient side. And so for that reason, we really do need to be thinking about patient priorities in the management of their EoE and when selecting therapy. And I really like this survey because it highlights a couple of things that we already know, but puts it in black and white, literally, which is that most everybody really wants to prevent complications and worsening of their EoE. That's a top priority, and that makes sense. And very few people don't want to not treat their EoE, which is just the same way of saying, a different way of saying the same thing. And also that there's some tension around this idea that if the doctor or the clinician recommends it, that's what I want to do. And in fact, more shared decision-making can occur when patients perceive their providers are comfortable with the patients choosing a therapy outside of the provider recommendation. So go back a couple of slides, we've already seen that there may be some habits that arise in terms of what's recommended up front. And so being open to that conversation and thinking through what is the best choice, not just what is the most efficacious choice, is really important. I want to highlight something else, which is some data that we presented last year. And I won't go through all of this, but this was a study where we surveyed and spoke to a number of older adults who were managing their EoE to solicit their understanding and their perspective of management. As we talked about at the very beginning, EoE is increasingly prevalent. And as people age with EoE, there will be likely more and more older adults who are managing this. And we wanted to explore whether their perspective is similar or in some ways contrasting with those younger adults and kids who are also managing things, because this can, of course, be diagnosed at any time point and people's priorities can change. And so just to highlight a few of these areas or domains that were illustrated by those who participated. I highlighted one domain, which was around social experiences. I think this really tracks for a lot of people, which is that, this is a quote now, it's embarrassing that you had to walk out on a group that you're having lunch with, how to manage those social experiences, how to manage swallowing function and concerns. Does this become cancer? Again, quoting from some of the responses, what about the diagnostic journey, the evaluation to getting an answer as to what's going on? People internalizing, I thought I was eating too fast. I was stressed when I was sitting down to eat, wondering what was going on. And then ultimately thinking about the treatment perspective. I'm very frustrated. I take a handful of medication in the morning. I used to be somebody that didn't even like taking Tylenol. So thinking through this, competing, again, priorities around managing perhaps some of the other comorbid issues or other underlying medical problems that may be going on, and thinking how that may change and evolve in the course of time. So we set out to quantify some of those preferences. This is a diagram, an example really of a question that we asked in a separate study, which is a discrete choice experiment. And I'll go through that here very briefly. As you can see, there are two options, treatment A and treatment. And unlike a prototypical survey where we might ask people to say, do you prefer this or that, or this or that, we ask people to think about the totality of the option. And as you can see here, there's a number of different factors. It's not going to necessarily represent all potential variables, but we isolated some that we thought were particularly important. How much time without symptoms? What's the likelihood of the treatment being able to reduce the inflammation that we're seeing at the time of biopsies? Was this treatment approved for EoE specifically, approved for something else? And what was the actual medication? Was it a biologic medication that wasn't necessarily otherwise specified specifically, or was it a steroid? And there was a number of different options, and then sequentially asking this question in different ways to try and understand what are those things about treatment that are particularly and most important to patients, and being able to put a number to that. And what you can see are some results here. And again, we're not going to get too deep into the weeds, but what I want to show is that a 90% chance of no inflammation is equivalent to about 15 months of time without symptoms. And so there's that relationship. And that this is over 7.5 times more important than the treatment being FDA approved specifically for EoE, and almost six times more important than the treatment type itself. And you can see that it's not as if these other aspects are unimportant. They are, and that's not to diminish that, but rather to show that controlling that inflammation and also avoiding symptoms are really top priorities, and those make sense. And what I think that suggests is it helps us when we are discussing this, especially when people are thinking about changing their therapy, what is it that is likely to achieve some of those goals? I will say that part of this exercise was providing standardized information, and that was utilized to help make those decisions when going through the study. And we use some of that same information when we leverage the results from that study to help in the development of a clinical decision aid, which is currently in process. And I also want to take a moment to say thank you so much to APFED, who's really been able to help support this, and we're extremely grateful for this and looking forward to continuing to work on this. But I want to highlight a couple of different areas that I think are really exciting. We were able to use just 3 questions from that original study to help us diagnose membership in a preference group. So high accuracy that we could be able to see with just a few questions and that standardized information, which included potential risks as well as potential benefits for different options, to put people into different groups. One, those to whom efficacy matters most. As we said, we know that efficacy is really important. Of course it is, but in this group, efficacy was of primary importance. Another group where FDA approval and treatment type also mattered. And then another group where the treatment type matters, but not so much FDA approval specifically for EoE. And after going through this exercise, which we anticipate would be done before a meeting in the clinic with somebody's provider, they can have an opportunity to review this information, select or answer these questions, and then it results in a summary statement of information. It looks as if you might prefer one or another treatment. It's not suggesting or saying that is the only option, rather that's a good starting point. And in fact, we think of this as a good analogy to somebody who's reading before class. It provides more context and more of an opportunity to make as much use of that clinic visit as possible. And this could be used for people who are just diagnosed, people who are thinking about switching, or in those in whom the current treatment isn't effective. And lots of different people fit into those categories and may potentially benefit, and really helps facilitate that conversation. We've had a number of follow-up interviews with people who've gone through this exercise. And what we found, in addition to very positive feedback, is that it's also helped provide some context for thinking about the management long-term. And that this isn't, as we said at the beginning, just something that we want to acutely manage in the moment and then kind of let fall off because of the likelihood of recurrence of symptoms. And that we really do want to be thinking about chronic management for a chronic. We've also published recently some other work, again, in service of trying to provide some additional context for people when they're meeting with their clinicians, or perhaps when they're learning on their own. What sort of questions should people be asking about this diagnosis? I won't go through all of this, but just want to highlight a couple of domains, as you can see on the left, and some of the sample questions for people to be researching or asking about when they're meeting with somebody. What is EoE? What are some of the most important causes? What should I do if I get a food infection? What are my treatment options? Should I start, stop therapies? We've highlighted the answers to some of these already, but really figuring that these are particularly important things that people want to ask. And this list was developed with a number of experts in EoE, and we're really excited to be able to share this. So I'd like to summarize what I've talked about already, which is that we should be moving, and I think are beginning to move, towards an EoE patient-centered model of care. That with increasing choices, we really do need to be moving in that direction. So when EoE is suspected, we should have efficiency in diagnostic evaluation. And then if EoE is diagnosed, we need to have a really good discussion about the treatment risks, the benefits, and also the alternatives. When EoE is treated, we need to think about the acceptability of therapy long-term. If something is going to be fine for a few months, but that there's going to be difficulty in adherence long-term, that may not be a great option, even if it is effective in the short term. And then again, thinking about maintenance, that need for surveillance and monitoring over time, that this is a chronic condition that we need to be thinking about as managing chronically. So I'll end with with a couple of conclusions. First, EoE is a chronic allergen-mediated inflammatory condition. It's increasingly common and it justifies long-term management. With the recent FDA approval for a couple of new medications specifically approved for EoE, and likely with more on the way, treatment options are expanding, and this area is increasingly complex. PPIs, smaller corticosteroids, biologic therapy, and elimination diets are all acceptable therapeutic options. Endoscopic dilation, I would add to that list as well, not because it's going to manage the inflammation, but it certainly is a good and effective way at getting people feeling better very quickly. And finally, given the current treatment options and expected continued complexity in the future, shared decision-making really is paramount in EoE care. I'd like to pause one more time here to put in a plug for an upcoming webinar. Dr. Brown-Whitehorn will be speaking in just a few weeks about managing persistent cases of EoE, so I'd like to highlight that. I'd like to thank APFED once again for the invitation. It really is a privilege and an honor to be able to speak with everybody. I am going to stop there, and I would be thrilled to continue the conversation with the time that we have remaining. So thank you so much again.
Thank you so much for your presentation. We really appreciate all your insights and the details that you went through with all the options that are available. We've got some great questions coming in. If you haven't submitted your question yet, please go to the Q&A tool on your screen and go ahead and submit your question. We're going to start having a follow-up conversation here with Dr. Leiman. All righty. So first question that came in, can narrowing of the esophagus get better on its own?
So there's a couple of ways to sort of think about that. If we think that this is inflammatory associated narrowing, there's sort of two categories that I might be thinking about. The first is there a focal stricture? So in other words, is there a single area or perhaps multiple areas within the esophagus that are narrowed, which oftentimes could be the source for where food's getting stuck? That scar tissue generally would not be going away on its own. There are some suggestion with some data in the last several years that perhaps some medications may be able to reduce that scar tissue, but that's early stages, and I certainly wouldn't hang my hat on that. And then there's the other aspect, which is really more diffuse narrowing, or what we call narrow caliber esophagus. Some of that narrowing can be related to edema or swelling from that inflammation. If that inflammation goes down, then usually some of that narrowing will get better, although not necessarily all of it. And so I would say that typically we would not expect this to resolve spontaneously, but rather with either a medication or a diet-directed therapy, we should be able to get significant improvement. And then if there are one or multiple focal areas of narrowing or strictures, that we can manage those safely and effectively with endoscopic treatments such as a dilation.
What are some ways to know if your esophagus is healing or getting better? Does it get easier to swallow?
Yeah, that really comes to one of the points that we made during the conversation, which is that there's a couple of different ways that we're thinking about success for the management of EoE. And it's really important to consider all of these together. So fortunately, as I said, right now, the best way that we can monitor for success is with an endoscopy and biopsies. See what things look like. The way they look with our scope generally correlates pretty well with the way they look under the microscope, which is why we took our biopsies. And hopefully in the future, and maybe even in the near future, there may be some other what we call minimally invasive or non-invasive ways to monitor for that. But for right now, endoscopy is the best way to assess healing in that regard. But of course, symptoms are really important too. And typically people will begin to feel an improvement in their symptoms if that healing is happening. I mentioned already that dilation is a way to frequently get people feeling better very quickly. That usually, that improvement is usually within days to a couple of weeks. Medical therapy or even dietary therapy typically expects several weeks or even up to a couple of months to begin to sort of noticeably appreciate a change. But I think, again, we really want to focus on integrating how people are feeling, and then also what we're seeing with our scope and on our biopsies, and consider all of those together. And just to kind of pull that thread even further, as I mentioned previously, there can be discordance between those two. And sometimes people can feel better even when there's still inflammation. Perhaps there's modest improvement, but there's still ongoing inflammation that puts people at risk for developing scar tissue, and we would want to think about that. Or there may be a circumstance in which patients are not feeling better, even though that inflammation seems to be controlled. Again, a different situation, but that may be the perfect time to think about trying an endoscopic dilation. Perhaps there's some narrowing that wasn't appreciated, and so one would need to go back and evaluate for that. Or perhaps there's other longer term questions around or concerns around angst about eating, and so there may be some ongoing symptoms related to the fact that there's been a lot of inflammation as an event. So really important points to consider when thinking about success.
Thank you. Next question is about the frequency of endoscopies. So in this case, the person's child is getting 2 to 3 upper endoscopies a year, which generally includes anesthesia and sometimes propofol. And so they're curious, are there concerns about the number of times a year someone goes under to get an endoscopy?
This is a question that I get a lot, actually. And I'll dispel one concern, which is that there's a number of endoscopies that somebody is allotted for their life and that they're not allowed to go over that number. That question actually comes up. And the answer is, there's really no set number. Obviously, we want to minimize the amount of times that people get anesthesia or get endoscopic procedures, because although these are safe, effective, they are not completely risk-free, both from an endoscopic standpoint, but then also with anesthesia, as this person has highlighted. The goal for endoscopy really should be to utilize this either to obtain a diagnosis, assess treatment response, and then surveil or monitor for how things are going longer term. Ideally, the fewest number of endoscopies that we need to make the diagnosis, the better. And hopefully we're choosing a treatment that is going to be both effective and something that's going to be able to get us to that, again, healing stage quickly. I would always advocate for monitoring for treatment success after initiating a change. And that's either going from nothing to starting something, whatever that something may be, or when switching between things, perhaps because something else wasn't working, or because it's just no longer compatible with somebody's lifestyle. Somebody may have chosen dietary therapy, and now they're in an environment where they can't adhere to that so easily, and so they want to switch to medications, for example. We want to make sure that it's working. There are really not great data for us to be able to say what the perfect interval is between endoscopies. Typically, I give people about 2 to 3 months to have some healing and then monitor for success. And then once we achieve healing, again, going back to the point about maintenance of healing, again, there's not perfect data around this, but there's agreement among experts that we should be monitoring this over time. I typically say if things are going well and symptoms are under control and other things are otherwise stable, that an endoscopy, perhaps every 2 or 3 years, again, to check in to make sure things are still going well is a good idea. And then when we think about interventions and more frequent endoscopies, usually we're thinking about that in a couple of different circumstances. One might be because there's a choice to make a elimination diet, the treatment option. And as I mentioned during the talk, that can sometimes require a lot of endoscopies relatively back to back as we work to isolate or identify the specific triggers that are causing it. And that may vary depending on whether that's a step up or a step down approach. And the other instance in which we may do this is, again, if we're thinking about somebody who has a lot of scar tissue, that fibrostenosis, where there's complications of that inflammation and needing to dilate that. And sometimes we would have people come back relatively short intervals to serially stretch that area out and to, again, achieve improvement or hopefully resolution of the symptoms.
We actually had an interesting follow-up question about that. Was people were curious, can dilation be someone's only treatment?
I think I heard the question was, can dilation be sort of monotherapy or the only treatment? And I brought that up in that initial case when we talked about, well, what might be the option? There's a couple important points to bring up about this. firstly, dilation can treat symptoms, it can treat the scar tissue, but it doesn't fundamentally treat the inflammation that's driving that scar tissue, that's driving this process. And so I would consider this a piece of our treatment portfolio, but not necessarily in most instances, the treatment that I would recommend for people long term. We usually want to use this as an adjunct rather than as the, again, primary method of therapy. There may be some instances in which there's difficulty finding a medication that's working, or there may be instances in which there's not much active inflammation. Sometimes people refer to this as burned out inflammation, where biopsies aren't showing much eosinophils, but there's a lot of scar tissue that certainly looks like it's EoE. In that case, the goal of reducing inflammation may be secondary to the goal of dilation and getting that area open. But I would say in the vast majority of instances, dilation as a treatment is really not recommended in the absence of treating the underlying reason or inflammation that's causing that process.
Thank you. We have a few questions that have come in about dupilumab. And so first off, they're curious kind of how long do you take it for? Is it for your lifetime? And what are the long-term side effects?
Really important questions to ask and things to consider when making that decision. I would always start off by telling any of my patients that we are not making a forever decision. We're making a for right now decision about our treatment. That would be true whether it's dupilumab or some other treatment option, even dietary therapy. That people change over their life, and what they want to choose may change in terms of their treatment. And of course, as I hinted at earlier, there are probably more therapies coming in the future as well. And so I would always start with that caveat. As of right now, we don't know what it looks like for people to be on dupilumab for their EoE for 5 or 10 or 20 years. We have a couple of years of experience, and so far it seems safe and effective. Dupilumab's been around for other allergic conditions for several years before that, so we do have some longer term data. But again, I would never tell somebody this is going to be your forever treatment. And of course, we want to make sure that it's working. Typically, just like I would with other treatments, I would recommend doing some sort of assessment after starting them on treatment. So in this case, again, several months after starting the dupilumab, we want to make sure it's working. Once we've established that it is working, we would continue. There are some things to consider, primarily because this is an injection. We want to make sure that people are aware of the proper technique for using it. Injection site reactions are probably the most common side effect. That would be true for other biologics or other medications that we're injecting as well. So good technique there is important. Thinking about storage and lots of things to consider in that regard. I also caution people that they may develop what might be like flu-like symptoms, usually for the first day or so after using the medication. That tends to be, at least anecdotally, early on when people are starting for the first several weeks that they're using it, some muscle aches, joint aches, that sort of thing. But again, that tends to get better over time. There are some other rare side effects, and those are good things to discuss with the clinician when you're sort of making those decisions. And again, thinking about the other aspects, which is in addition to the efficacy, but also, again, adherence. And I have a number of patients who are making some decisions about their treatments based on their ability to adhere to whatever that option is. Perhaps they don't need a medicine that's going to work 80% of the time because something else may work, but if they can't remember to take their medicine or their schedule doesn't allow for them to take their medicine twice a day, in some instances every day, that once a week medication makes the most sense for them. So lots of things to consider when making that decision.
A more specific side effect question that also came in about dupilumab is the question about safety in planning and pregnancy.
Yeah. So again, that sort of highlights one of the things that we talked about in that sort of initial patient discussion, which is how do you sort of navigate some of those things. And there's probably a couple of ways to think about that. Patients who are pregnant were excluded from the clinical trial, so we can't say definitively the safety there. There are some longitudinal evaluations. So again, this has been around for more than 2 years for other allergic conditions. The dosing is a little bit different. And of course, these are people who may not have EoE, but there's nothing that specifically shows a signal about risk in pregnancy. But I would caution that this is something that's not been specifically studied. And so that would be an important conversation to have with your treating clinician as well as OBGYN, thinking about the risks of medication, balancing that with the risks of the EoE itself. And I think that would be true whether it's dupilumab or steroids or acid suppression like with PPIs. Some people do think about drug holidays, although I've spent a lot of time talking about how we want to maintain therapy over time, that pregnancy is a time in which many people want to simplify their regimen, and that comes with some risks, as we've discussed, of recrudescence or recurrence of that inflammation. So thinking about balancing that, I think it really does highlight a lot of the complexity around this, and that these are individualized decisions. And again, that really emphasizes the importance of that shared decision making and thinking about, well, how are things going with my EoE right now? How am I sort of managing that versus what is my potential risk tolerance for using treatment right now, or perhaps holding off on something, or maybe not initiating something until after. And that's something that also comes up because when we're monitoring for success, also considering what about the anesthesia risk, perhaps during pregnancy, or if somebody is choosing to breastfeed, thinking about those issues as well. So there's a lot that's kind of tied up in that. And really, I think, again, illustrates why this is it's a complex area to discuss.
The next two questions are kind of related, so I'm going to pair them up. Is EoE related to Mcast? And does Xolair help EoE at all?
Yeah, thanks for those questions. So, these are patients with EoE, people who are diagnosed with EoE or other conditions, are oftentimes balancing their other allergic issues. And in general, when somebody has a question about mast cell activation, I do like to have allergists involved. And that's a really important point here, which is that to emphasize there's a team that should be thinking through this. For example, if we're doing dietary treatment or elimination diet, I always insist that people see somebody from nutrition or a dietitian to help logistically organize that. If there's a question of some other coexisting allergic condition, I certainly want to have an allergist or an immunologist available to help us out when thinking through some of these decisions. The medications that I discussed today, some of them are off-label, some of them are, of course, now on-label for EoE, but the treatments that we went through are really the primary effective treatments for EoE right now.
Thank you. So I'm going to throw you another curveball that you haven't talked about yet. Can probiotic help manage symptoms?
I think the question was, can probiotics help with symptoms? And the answer is maybe. I think that this is a question that comes up in GI clinics frequently. There's a lot of advertising and marketing around both prebiotics and probiotics and gut health. And I think those are something, again, that many people are learning about, thinking about. There is no recommendation to use probiotics in the management of EoE. There's certainly areas of study in terms of thinking about what's called the microbiome, which is, again, that idea that the esophageal milieu or environment may be altered in people who have EoE. Again, we talked about how there should never be eosinophils there, and when there are, we need to think about that, and then thinking about how that may or may not impact the microorganism environment there as well. But again, I would emphasize that there's no data to suggest that prebiotics or probiotics would be effective. That in reality, we know that many people take these and feel some improvement. And I don't have any evidence to say that people shouldn't be taking these. So I do consider this on a case-by-case basis, that if somebody says, I feel much better taking it, I'm usually supportive of that as well.
Ready. Next question. Are there patients that are non-responsive to most or all of the current available therapies? And if so, is there any data showing why that might happen?
Yeah, that unfortunately can occur. So we showed kind of a number of different treatments and they have varying efficacy. So just to kind of think about these in sequence, many times people are put on PPIs, those again, acid suppressing medications up front. Efficacy, generally speaking, probably around 40 to 15%. The swallow topical steroids, generally around 50 to 60%. Dupilumab, probably a little bit higher efficacy, at least based on the data we have, maybe closer to 70 to 80%. You compare that to dietary therapy. I showed you, depending on the type of diet somebody might choose, efficacy may range between perhaps 40 to, again, 70%. But you can now see that there's some people that may not respond either to one or all of these treatments. There is another dietary treatment that we didn't discuss quite so much, which I don't usually prescribe in the adult world, but certainly is something that may be considered in the pediatric practice more, is an elemental diet. And that has an even higher success rate than some of these empiric elimination diets, probably closer to 80 to 90%. This is a lot harder to adhere to for lots of different reasons. Logistics, costs, et cetera, may influence that, but the efficacy is even higher. But what that also shows is that even with an elemental diet that's sort of devoid of all of these allergens, there is still stuff in the air, these aeroallergens, things that we're breathing in that's much harder for us to control that may be triggering ongoing inflammation. And so that gets back to a point I made a few minutes ago, which is around the healthcare team who's managing this and thinking about how important it is to manage coexisting allergies if they're there, because the better in general some of the other allergic issues are controlled, the better the EoE, and then vice versa. So if somebody has tried a number of different options and they've sort of not responded for a number of different reasons, we've excluded some other reasons for this inflammation to be present. We've thought about a dilation or stretching of the esophagus to make sure that it's not a mechanical problem that's causing this. And we've run through all of this and we're still not there. There is still an opportunity to consider a clinical trial. There are a number of ongoing clinical trials for patients with EoE. It's fairly easy to search for different studies that are recruiting. There's a clearinghouse for this called clinicaltrials.gov. If somebody searches for EoE and they search for their location, they should be able to find some ongoing studies. Fortunately, as I said, there's a number that are actively recruiting. And of course, each individual study is going to have its own criteria, but I would always emphasize that there, again, are some other options beyond just what we would consider our usual standard of care when thinking about people who aren't responding despite a lot of different interventions.
Thank you. We've got so many wonderful questions coming in here. Let's see. All righty. So we've talked about a number of different things today. One thing people are interested in revisiting is PPI therapies for a moment. Can you talk briefly about the long-term effects of PPI therapy for EoE?
So thank you for this question, because again, this is something that comes up very commonly in my clinical practice, and I think it does for a lot of other folks as well. PPIs have been on the market for about 35 years. And so compared to some of these other treatments, these are medicines that we have a several decade-long history with. I typically counsel people when we're thinking about starting these medications that there are a number of potential side effects that have been described. These are primarily in the context of associations, large studies that I've found that the use of these medications with the use, has been associated with the development of one problem or another. And so we consider those potential side effects. When we think about the best evidence for this, which would be a randomized controlled trial, we found that at least within the context of these clinical trials, there's really not been any definitive cause between the PPI use and these side effects, with the exception of a small increase, which is statistically significant in what's called a non-C. diff enteric infection. So these might be things, for example, like coli, et cetera, that people may be slightly more at risk for. And there are, as I said, a number of other potential side effects that are worth considering, but the data for those is just not quite as strong as it is against them. But certainly worth discussing and considering. These are things that are on people's minds, and they're seeing a lot in advertising and other sources in both the lay literature as well as in the medical literature regarding, again, these potential side effects. And so when thinking about long-term treatment, as I said before, I would always counsel people that this is not a forever treatment, but it's for now, and that we can always and really should revisit whatever our choices are, making sure that it's still working and that it's still acceptable for people. I think we should always be open to the idea that new data may come out, which suggests that this is a better or worse option, or for some reason we should or shouldn't continue it. But I would emphasize that these are effective. I showed some other data around the dosing. Ideally, we want any medicine that we use to be at the lowest effective dose. That would be true for lots of different things. That's not just restricted to EoE or just restricted to PPIs, but that's a really important aspect to emphasize as well, that again, we want to be using the lowest dose that's effective for managing the inflammation as well as the symptoms.
Well, thank you so much for taking your time with all these questions. We've got lots of great questions coming in here. And so I think what we'll do is follow up with you offline to see what we can't do to continue answering more of these. And some of these are great questions that we'll be able to talk about in our next one. So I also want to make sure to thank our education partners for their support of this webinar series, including GSK, Sanofi, and Regeneron. So as Dr. Leiman alluded to, our next webinar is on September 17th, featuring Dr. Terry Brown-Whitehorn. She's going to talk about managing persistent cases of EoE. So it's going to be a great opportunity to really continue the discussion about treatment. Other great ways to continue learning about eosinophilic disorders is by watching on-demand sessions from our annual patient education conference, EOS Connection. This year's conference was held in Washington, D.C. in July, and the recordings of all the sessions are available online to watch for free through the end of the year. So I encourage you to go to APFED.org/conference, register as a virtual attendee for free, and check out all the presentations. You can also continue learning by subscribing and listening to our podcast, Real Talk Eosinophilic Diseases. Our latest episode that released this morning features Dr. Elizabeth Jensen talking about findings from the EGID Partners Registry. I encourage you to check it out at apfed.org/podcast, as well as subscribe to Apple Podcasts, Spotify, and other podcast places. Finally, to continue the conversation with other people impacted by eosinophilic diseases, consider joining the Inspire Network. APFED's online community there at apfed.org/connection. It's a great place to connect with patients and other caregivers. So thank you again for joining us for today's EOS Support webinar series. If you have a question that didn't get answered today, please email mail@apfed.org, and we hope that everyone has a great afternoon.